Start at 8. Assalamu alaikum, everyone. Can you all hear me? Okay, I think we should begin. So, hello. Yes, I'm starting, Dr. Sidra. I'm starting, and we will continue with your lecture. So, hello, everyone, and thank you all for joining us today for this very insightful topic on complex regional pain syndrome. We all appreciate your time and commitment to enhance your knowledge and understanding of this much underrated and crucial topic in chronic pain, especially. So, before we begin, I would like to introduce our honorable speaker, Dr. Sidra Javed. She is a senior anesthesiologist and pain consultant who is currently leading the chronic pain services and anesthesia services at Shaheed Motarma Benazir Bhutto Trauma Center of Karachi as assistant professor. She has done FCPS anesthesia in 2018, and she also holds a gold medal in FCPS anesthesia from College of Physicians and Surgeons. Dr. Sidra has experience of working and obtaining a Penn Fellowship from Aachen University Hospital as a Penn Fellow, which was led by Dr. Gohar Afsham, Professor Dr. Gohar Afsham. And so before we begin our lecture by Dr. Sidra, I would all like to request everyone to mute their mics so we don't have any disturbance in between. I think we can start, Dr. Sidra.
Okay, thank you, Dr. Aksa. I'm Dr. Sidra Javed, and today I'm going to discuss the topic complex regional pain syndrome. I have no conflict of interest to declare. Okay, a 53 years old male complains of severe wrist pain. He had history of casting because of distal radius fracture. The pain is burning since 1 year, with accompanied by numbness and tingling, and the pain increased by touching his skin. His hand skin is dark red and often swollen, and he complains of decreased range of movement. So, what is the historical perspective of CRPS? It was first described by Mitchell after the American Civil War in 1872, when he encountered soldiers who were injured by gunshot wounds, exhibited bizarre symptoms, and coined the term causalgia. Then, in early 20th century, Peter Swedick described features of pain, swelling, and identified the localized bone atrophy by X-rays, Swedick's atrophy. Following minor injury to limbs, hence this phenomena came to call Swedick's atrophy. Then, few years later, its association with the sympathetic nervous system was recognized, and hence the term reflex sympathetic dystrophy was increasingly used. But now these terms are changed. Before going into the topic, you all should be familiar with these terms, especially hyperalgesia, allodynia, and central sensitization. What is hyperalgesia? It is an increase in pain to a stimulus that is normally painful. And allodynia, it is a pain evoked by stimulus that does not normally provoke pain. What is central sensitization? Normally, after excitation of any painful stimulus, nociceptive neurons in the dorsal horn of spinal cord resulting from tissue damage cause damage or inflammation. But if there's an increased excitability of nociceptive neurons, this is called central sensitization. Complex regional pain syndrome is a debilitating, painful condition associated with sensory, motor, autonomic, skin, and bone abnormalities. The pain experience is disproportionate to the degree of tissue injury and persists beyond the normal expected time for tissue healing. Okay, CRPS commonly arises after injury to dead limb. However, there is no relationship to the severity of the trauma, and in some cases, there is no precipitating trauma at all. Previously, there are only two types were diagnosed, that is CRPS type 1 and type 2. Type 1, traditionally known as reflex sympathetic dystrophy, in which there is without an identifiable peripheral nerve injury. and type 2 with a peripheral nerve injury. Now, the third time is also in this. There's CRPS NOS or complex regional pain syndrome not otherwise specified. It is a diagnostic subtype of CRPS for patients who don't fully meet the Budapest criteria for CRPS, but can't be diagnosed with any other diagnosis also. So why it is important to know this topic? As you all know that in the McGill Pain Index, the complex regional pain syndrome even comes after the childbirth. Childbirth pain score is below 40, but the complex regional pain syndrome is above 40. So I think if we can understand the pathophysiology and diagnosis, then we are able to treat the patients. Pathophysiology. Even now, the exact mechanism is still poorly understood, but it shows that both peripheral and central factors are there in this pathophysiology. Okay, after any tissue injury to an extremity, it results in minimal nerve trauma or tissue trauma that cause local release of pro-inflammatory cytokines, interleukin-1, 2, tumor necrosis factor, bradykinin, and septal T, and decrease in the interleukin factor, anti-inflammatory mediator interleukin-10. Okay, these all causes inflammation of the local tissue and also caused increased nociceptive responsiveness. That is called peripheral sensitization. Okay, the response is exaggerated in individuals susceptible to CRS having some genetic factors also. The nerve trauma may also lead to decreased sensitivity, density of nociceptive fibers, and altered innervation of sweat glands and hair follicles and affected area. Okay, after initiating injury, nociceptive fibers in area begin to express some adrenergic receptors, and circulating catecholamines can direct trigger nociceptive firing. Circulating ketamine enhances because of some emotional arousal, psychological factors, distress after surgery. Okay. There's also decrease or reduced sympathetic outflow in the region after initiating trauma, and that cause signs of vasodilation initially. So in the initial stages of CRPS, there's vasodilation, warm peripheries. On the other hand, decreased sympathetic outflow obstruction also causes upregulated sensitivity of local adrenergic neuroreceptors and catecholamines that cause in the later stages vasoconstriction, dense vasoconstriction that decrease the regional blood flow in that limb or that area. And because of the decreased blood flow, there's local hypoxia, nutritive defects, some release of free radicals, endothelial damage, and also the increase of pro-nociceptive substances that cause hyperalgesia. Okay, from the peripheral sympathoefferent coupling here, then the firing goes into the central area in the spinal cord, where the sympathoefferent coupling cause spinal nociceptive pathways alteration that cause central sensitization. And in the end, it also causes some changes in the brain itself that causes decreased limb representation of the affected area. And because of these sensations, it causes altered perception and movement of affected limb. So we can say the pathophysiology started from the inflammation, then the sympathetic system, genetic involvement, central area, that is central sensitization, and also in the brain, decreased representation. Brain plasticity also changes, and psychological factors. So if we are able to know these all changes, we can manage the patient step by step. Here is also a summary of these all pathophysiology, altered cutaneous innervation, central and peripheral sensitization changes, altered sympathetic nervous system function. One thing is important, then here initially there is a vasodilation. Then in later stages, vasoconstriction that cause hypoxia. So initially, if we give a cold challenge test in these patients, vasoconstriction is absent in initial acute CRPS. But in chronic CRPS, there's intense vasoconstriction. Also, Also, there is a change. Main important is the psychological factors are also important. So, if a patient is in extreme distress, any other stress, it can also increase sensitivity to catecholamines that can cause increased pain of this. Exact etiology is also unknown, but in some instances it shows that extremities trauma, fracture most common, mainly orthopedic fracture, patient came with a stroke, and even minor injury like sprain, contusion, crush injuries can cause CRPS. Most cases are between 35 to 70 years of age with female predominance of 3:1. And the risk factors are osteoporosis, menopause, patient on smoking, asthmatic patients, and patients taking angiotensin converting enzyme inhibitor. Patient came to us with severe constant pain. As I already discussed, it is often disproportionate to the initial injury. That is, even a sprain can cause intense debilitating pain with associated hyperalgesia, allodynia, and hyperesthesia. The pain is usually described as stabbing, penetrating, throbbing, and burning in nature. And it is accompanied by vasomotor, pseudomotor, and trophic changes. Vasomotor are temperature changes, skin color changes, and pseudomotor means edema changes or any changes in sweating. And trophic changes means there's a decreased motor weakness, hair and nail growth changes. The physical examination should be done simultaneously in both limbs to compare temperature, sweating, color, swelling, or dystrophy. And last but not the least, neurological and vascular examination should also be performed to make sure that the presenting symptoms are not explained by any other central or peripheral nerve injury or vascular pathology. Sometimes they also came with tremor and dystonia. So this is only a mnemonic for the trainees to learn the clinical features of complex regional pain is from STAM. As for sensory, T for trophic, A for autonomic, M for motor, and P for pain. Just for trainees. So what are the diagnostic criteria? As there's a lot of mechanisms in pathophysiology, so how we can diagnose it? The International Association for the Study of Pain came up with the first set of diagnostic criteria, which shows presence of an initial inciting event, allodynia or hyperalgesia out of proportion for the inciting event. There it should be evidence with skin changes, pseudomotor function or edema, and the absence of any other syndrome that would otherwise explain the presenting syndromes. However, it was soon found to have low specificity and often led to misdiagnosis. Then the Budapest criteria was developed in 2003 and it shows continuous pain. CRPS is a continuous pain that is disproportionate to any inciting event and patient must report one symptom in 3 of the following 4 categories. Sensory, vasomotor, pseudomotor, and motor. In sensory, allodynia or hyperalgesia. In vasomotor, temperature asymmetry of both arms or skin color changes. In pseudomotor, edema or changes in sweating. And in motor trophic, decreased range of motion, motor dysfunction, and changes in hair and nail growth. And must display one sign at the time of evaluation in at least 2 of the following categories. And this shows CRPS type 1 and type 2. It is still used Budapest criteria and trainees should learn this criteria by heart. Then in 2010, Harden and colleagues developed the CRPS severity score. Okay, it included 17 different symptoms only with 1 point for the presence of each symptom. And it shows that the higher scores had greater correlation with increased pain and functional limitation and better measurement of response of treatment. And these are the 17 symptoms. Half are the symptoms that were self-reported, that is allodynia, temperature asymmetry, skin color asymmetry, and trophic and motor changes, decreased range of motion, and asymmetry edema. And half are the symptoms that observed at the time of examination. Hyperpathia to pinprick, allodynia, temperature asymmetry on palpation, skin color asymmetry, sweating asymmetry, trophic changes, motor changes, and decreased range of motion. You all should know this criteria also. The International Association of Study of Pain, CRPS Special Interest Group, convened a workshop for CRPS experts in Spain in 2019 to review the diagnostic tests and issues identified in applying these criteria in both research and clinical contexts. And following the workshop, adaptations were made to the diagnostic taxonomy. These are some adaptations, as I already discussed. They said that CRPS to be primarily categorized as the chronic primary pain, and there's also introduction of a third CRPS subtype, as I already mentioned, CRPS NOS, not otherwise specified. And they said that the CRPS can progress and can extend to another limb also, but to label both limbs as CRPS, which the fully diagnostic criteria must be applied to each limb individually. And they said that extension of pain alone to other limb is not formally considered to spreading CRPS. And clarification that the diagnostic signs of CRPS type 2 must extend beyond any identified injured nerve territory. In this, nerve injury mentioned, but it should be extend beyond this also in tissues, in other areas. What are the diagnostic tested? CRPS is basically a clinical diagnosis, but there's no special diagnostic test. But the main purpose for diagnostic test is to rule out other diagnoses, other pathologies. Like in lab tests, we should do CBC, ESR, CRP, and anti-nuclear antibody to exclude infection, inflammation, or autoimmune pathologies. Okay, as I discussed, inflammation is present in CRPS, but in CRPS inflammation, there's not increase in leukocyte count, CRP, and ESR. So if these increases, it means there's any other pathology also. We also should do ultrasound to rule out any peripheral vascular disease, nerve conduction test to exclude peripheral neuropathic disease or diabetes, and X-ray may demonstrate osteoporosis in affected limb, but it is not of diagnostic value. Objective testing like thermography to rule out the difference in temperature in both arms. Triple phase bone scan and MRI is not necessary, but in some cases it may be used. Triple phase bone scan method is best to rule out type 1 CRPS. In this, we insert or we do dye test by bisphosphonate. And if the higher uptake of the bisphosphonate or the substance means increased bone metabolism and the body part could be affected. It has better sensitivity than MRI. And diagnostic tests like sympathetic blockade for upper limb striate ganglion block normally, and for lower limb lumbar sympathetic block. It's mainly effective in type 1 CRPS, but can affect type 2 also. If the pain relief after this, it means it is a sympathetic mediated pain. So it is useful as a diagnostic and therapeutic both. But stages, there are 3 stages of CRPS, but not necessary that every person came from first stage, second, and third. It can correlate or interlink with each other. In CRPS stage 1, it is also known acute CRPS. As I already mentioned, in acute, there's a vasodilation, initially inflammation, vasodilation. So because of vasodilation, skin is warm, swollen, and inflamed. Later, color may changes. In distribution, pain is not compatible with a single peripheral nerve, trunk, or root lesion. Vasomotor changes, disturbances occur with variable intensity, producing altered color and temperature. X-ray is normal, but bone scan may shows increased uptake. In motor, there's decreased range of motion. This is the type stage 1 with inflammation, swelling, red skin, and shining skin because of vasodilation and temperature increase here. Warm temperature as compared to normal arm. In CRPS stage 2, that is also known as dystrophic stage, from 6 weeks to 1 year, skin now begin to cool because of vasoconstriction. Now, moist, tight, shiny, and swelling also and now the hair and nail changes also occurred. Brittle nails, sparse hair, discolored. Vasomotor shows motor and synaptic areas, and there's still motor weakness and decreased range of motor. This is the second stage. Mottling starts, and the temperatures begin to start cold from the second limb. Third stage is atrophic stage. In this stage, there is ulcerations and brittle skin, brittling of nails occurs, and cold patients' peripheries are cold as compared to other limbs. And in motor, there is extreme decreased range of movement, weakness, muscle and tendon atrophy, and even contractures occurs because of disuse of that limb. This is the atrophic contracture and ulcerations in the affected limb. Here are some of the differential diagnoses like neuropathic pain syndrome, peripheral neuropathy, any other radicular neuropathy, vascular diseases that include thrombosis, Raynaud's phenomena, inflammation like rheumatological arthritis and bursitis, myofascial pain syndrome, other psychiatric syndromes. How to prevent this debilitating condition? So some studies have shown that supplementation with vitamin C, 500 milligram per day for 50 to 60 days immediately after any injury or surgery helps reduce the risk of developing CRPS. So we can give vitamin C to our patients, to every patient. What is the treatment of this debilitating condition? So if you learn pathophysiology of that, you can treat one by one the pathophysiology and treat according to it. So it is a multidisciplinary treatment. The primary aims are to reduce pain, preserve function, and enable patients to manage their condition. There are 4 P's or 4 pillars for the treatment of complex regional pain syndrome. Number 1, important is patient education and information. Second is physical and rehabilitation. Third is psychological intervention. And fourth, last but not the least, is pain relief by medications or interventional procedures. Patient information is very important to support self-management. And goal setting, as we should inform the patients all the pros and cons and all the pathophysiology. We should teach the patient the pathophysiology of CRPS. As the patient told that there's only a minor trauma, minor injury, why this kind of pain? So we have to teach the patient and her or his family as also. Second, physical and vocational rehabilitation is very important, even the first line of treatment. In BCQs, if you ask what is the first line of treatment, side by side with medical management or pain medication, so physical rehabilitation is the first line of treatment. There's general body reconditioning through graded exercises. Graded exercises means step-by-step exercises. Desensitization with tactile and thermal stimuli. Tense strategies, aquatherapy, mirror therapy. Mirror therapy is very important in these types of pain. How it works? We put a mirror and the affected limb, like CRPS affected limb, put behind the mirror, and the normal hand is put front of the mirror. And the patient asked to keep quiet and look in the mirror, the normal hand. Then start moving both hands simultaneously. And it looks like, and in the brain, it pricks in the brain that the diseased hand is also moving. And he can do it daily for 5 to 10 minutes for weeks or months. There was favorable improvement in pain intensity and physical functioning outcomes, level 1 evidence following physical and mirror therapy for CRPS, and transcutaneous electrical nerve stimulation providing modest pain relief and function improvement. It is also level 1 evidence. In this, we, by the help of electrode, we provide current and sensations to the patient that cause tingling sensation and other type of sensations. It works sometimes in gate theory. Psychological intervention is also important. As we discussed in pathophysiology, that the increased expressions of catecholamines increase because of emotional stress, trauma, depression. So cognitive behavioral therapy is very important in this type of pain, even in all chronic pains. So patient learn to cope the skills, and it is also important to support cognitive behavioral therapy is also important for his or her family. It shows how to cope up with depression, with negative thoughts, other things. Pharmacological pain management is multimodal analgesia. What are the drugs that we can use in this? Okay, there are many drugs. Some have good efficacy, some have low efficacy, but by combining these, there's a good effect in these. So, because initially there's inflammation in the CRPS patient, for inflammation, we can use anti-inflammatory drugs like NSAIDs. So, evidence of efficacy in early part of disease, NSAIDs have a role in early part of disease. And a short course of systemic steroids also reduce CRPS pain, like a short pulse therapy of methylprednisone 100 milligram per day, reducing 25 milligram per day every week, has a good role in early part of disease. Okay, both oral and IV bisphosphonate are effective in reducing pain. It is level 1 evidence and also cause improving functionality of the patients. It caused by decreased bone resorption. As in CRPS, there's a increased osteolytic lesions or bone osteoporosis increases. So it has a very good role, but it is not first line of drug. IV ketamine is now shown to reduce pain intensity, but some says that because of intolerable side effects like neurotoxicity and liver failure, we cannot give it repeatedly. But in new guidelines, it shows that IV ketamine infusion for 5 to 7 days is a very good effect on CRPS patients. Low dose IV ketamine infusion. There's a role of gabapentinoids or tricyclic antidepressants, but there's not a proper any proper effect. That it has been a lack of evidence of efficacy, but still we use these as the first line of drugs. Gabapentins, anti-SSRI, SNRI, and other drugs. There's also a role of alpha-2 agonist, that is sympathetically mediated pain in CRPS led to use of phenoxybenzimine and clonidine. Opioid role is still controversial, and there's some effect by applying topically ketamine, amla cream, lidocaine plaster, and capsaicins. They decrease allodynia and hyperalgesia to up to some extent. Okay, what are the interventional treatment to treat these patients? Sympathetic plexus blocks, spinal cord stimulation, because the central sensitization occurs at the spinal cord level, especially at dorsal root ganglion. So dorsal root ganglion stimulation can also occur, and intrathecal drug delivery of antispasmodic drug like baclofen. Current evidence suggests that sympathetic ganglion or plexus block is associated with meaningful pain relief in CRPS patients, level 1 evidence, and dorsal column spinal cord stimulation is effective in treating pain from CRPS, also level 1 evidence, and it is also approved by FDA for this indication. Okay, now the recent evidences showed that continuous spinal ganglion block and continuous infraclavicular brachial plexus block were equivocal in reducing pain and edema and improving range of motion. So we can also apply infraclavicular block in these type of patients, as we can pass catheter in these infraclavicular area. So this is the summary of conservative medications and intervention therapies. I'm not going through detail. Stellate ganglion is important in this aspect that it is for trainees, that some examiners after CRPS scenario and CRPS questions, they asked for upper limb, they asked stellate ganglion block. Brief discrimination, brief summary, and then they asked what are the complications, contraindications, and side effects of stellate ganglion block. So I'm not going into detail, but what is the anatomy? The stellate ganglion is a sympathetic ganglion formed by the fusion of inferior cervical ganglion and first thoracic ganglion. and located at the level of C7 and near to the transverse process of C7. Nearby structures are brachial plexus, spinal nerve roots, vertebral arteries, subclavian artery, and cervical pleura. So we should not interact with these structures. Even 1 ml of our drug in the vertebral artery can cause fits. Contraindications you all should know. Number 1, patient refusal, coagulopathy, recent MI, pathological bradycardia, and glaucoma. Should I go into pre-procedure block? Will we have time? Okay. Pre-procedure block, patient must have normal clotting value, informed written consent should be given, IV access should be adequate, emergency resuscitation kit should be available, lipofundin should be available, and patients monitored with ECG, pulse oximeter, and blood pressure throughout the procedure. Stellate ganglion can be done through surface landmark, fluoroscopic, ultrasound guided, and CT guided, but normally fluoroscopic or ultrasound guided should be used. Should be the position of the patient? Supine position with neck slightly extended and the head is kept straight like this. Straight head, supine position, and mouth slightly open. Transducer is placed perpendicular to the tracheal axis at cricoid cartilage. This is cricoid cartilage perpendicular to the long axis at this level. We can go in plane in this for this block. Okay, move inferior and lateral to visualize Jessicness tubercle, that is the C6 transverse process. And the point of needle puncture is located between the trachea and the carotid sheet at the level of cricoid cartilage. Then after make cutaneous anesthesia with this wheel of local anesthetic, 25 gauge 1 inch long bevel needle inserted, needle between the transducer and the trachea, penetrate prevertebral fascia, and then inject 0.5 ml longus coeli, 0.5 ml drug after confirming the longus coeli muscle and inject 5 to 8 ml. Okay, some examiners also asked what are the points of successful stellate ganglion blocks or what are the side effects. Okay, complications separate and side effects are separate. So these are also known as side effects or successful stellate ganglion block, which includes meiosis, anhidrosis, ptosis, flushing of the extremities, and increase in temperature of extremity. Okay, and we should explain this to the patient also before performing the block. A study of the efficacy of stellate ganglion block in complex regional pain syndrome of the upper body was done, which shows that the overall mean pain reduction was 73.2%, considering spontaneous, and 55.8% on provoked pain. And serial blocks attained an average reduction in pain by greater than 3 numerical pain scale points from the baseline. Now, these are the complications which should be avoided. Hoarseness, intravascular injection, as I already mentioned, even 1 ml of injection at the vertebral artery can cause seizures. Pneumothorax, epidural intrathecal injection, phrenic nerve block, brachial plexus block, thyroid injury, hematoma, infection. Here are some of the recent advances in CRPS. Intervention for treating pain and disability in adults with complex regional pain syndrome and overview of systemic reviews. It included 6 Cochrane review and 13 non-Cochrane systematic reviews, which shows that oral corticosteroids improve composite CRPS scores compared with placebo. Bisphosphonate effectively reduce pain in CRPS 1 only, not in 2. Calcitonin more effective at reducing CRPS-related pain than placebo. Gabapentin not effective in reducing pain in CRPS 1. And NMD receptor antagonist like ketamine is effective for CRPS-related pain till 4 to 11 days. Spinal cord stimulation reduces pain and improves patient's own perception of overall improvement for up to 2 years. And acupuncture may offer short-term improvement in pain when added with rehab. Next, Does evidence support physiotherapy management of adult complex regional pain syndrome type 1? A systematic review. As I already mentioned, that physiotherapy is the first line of treatment. So 11 studies included 5 randomized controlled, 1 comparative, and 5 case series, which showed that significant reduction in pain intensity and swelling occurred immediately after 6 weeks of graded motor imagery. Graded motor imagery includes mirror therapy and other physiotherapy. Mirror visual feedback appears to reduce the pain perception. So I concluded my topic with that. There is a very good quality level 2 evidence that pathophysiology consists of greater motor imagery combined with medical management is more effective than physiotherapy. CRPS is a chronic, debilitating, painful condition. Early diagnosis and management is essential to help patients and reduce suffering from this debilitating condition. For this, a multidisciplinary approach to management has been shown to be beneficial, with particular emphasis on patient education and support. Any questions? So if you learn the pathophysiology of CRPS, you can treat the patient accordingly. If the patient is in the initial stage like inflammation, you can give anti-inflammatory, NSAIDs, anti-neuromodulating drugs. If there's a psychological factor, you can do cognitive behavioral therapy. If there's a central sensitization and some other decreased range of motion, you can do physiotherapy. Any questions?
So we have one question.
Yes, yes, Aksa.
Yes, we have one question from one of the participants, Dr. Sidra. They are asking for the volume and the concentration of bupivacaine or any local anesthetic that can be used for the stellate ganglion block, along with the adrenaline.
So as I already mentioned, then normally we use 4 to 5 ml of volume and in the concentration of 0.25% or 0.1 to 5%. It depends according to physician. Some use only lignocaine with adrenaline, do not use bupivacaine, and some physicians use bupivacaine. Next question, can we administer ketamine sublingually? I never use ketamine sublingually, but ketamine syrup is now used. We can give ketamine syrup.
I think sublingual ketamine is not even available in our country. So yes, the syrup can be used in the oral form.
How bisphosphonates help in CRPS? Bisphosphonates basically decrease or reverse osteoporotic changes in bone. As I already mentioned here, the mode of action. The proposed mechanism of action is that the medication modulates inflammation, thereby reducing bone microenvironment acidity and reduce bone resorption, helping improving pain and mobility. Yes, magnesium sulfate also has some sort of can occur, relieve pain in any chronic pain, magnesium sulfate. Another question is, are we strictly looking at normal inflammatory markers while having CRPS, or they can be increased as well? As I mentioned, that normal interleukins and other mediators increases, but TLC count, ESR did not increase in this type of inflammation. Yes, ketamine syrup is available in Karachi, but I think only at Afan. Aksa? I think it's available only at Afan.
Only at Afan, and it is customized, for the patients. It is not
for every patient.
given.
Only
Yes.
OPD patients or
Inpatients and OPD patients, we can
okay.
to the pharmacy to make formulation for us. Actually, it's not readily available. It's patient to patient customized drug.
And what's the effect of ketamine syrup? Good.
It is good, but it is usually not effective in CRPS, or we haven't been given in the patients with CRPS. We only use, as you mentioned, the low dose ketamine infusions for a few hours for several days just to reduce the symptoms.
Yes, during my fellowship, one patient came from USA for CRPS treatment, and we admitted him for 7 days, and we gave a ketamine infusion low dose for 7 days, and his pain score decreased from 7 to 8 by 10 to 2 by 10.
Yes, there is a very positive current evidence for the use of low dose IV ketamine infusion, and after the patient has any positive treatment, any positive sign by using ketamine, we can continue with the oral ketamine. Uh, it's the choice of the patient if he or she feels that it's going to affect him or her.
Another is, if we use ketamine, we keep patient in the hospital? Yes, for ketamine infusion, we have to keep the patient hospital, and 4 or 6 hourly monitoring is important. We have to give midazolam, pyrrolate, and other drugs with ketamine also. And patient should be awake but pain-free. Any role of radiofrequency or chemical neurolysis? Yes. We can use phenol and alcohol at lumbar after the diagnostic lumbar plexus block for therapeutic purpose. Any other question? How many trainees are there at the moment? Any trainees? The CRP is a very important topic for examiners.
So thank you once again, Dr. Sidra, for this versatile talk in a very simplified way and answering all the questions for the participants. I would again like to request the participants. I have shared the link for filling out the feedback forms to get their e-certificates. And I would like to request Dr. Asma, if you are online with us, that for your valuable comments.
Thank you, Dr. Aksa, for the moderation, and I'm really grateful to Dr. Sidra Javed for accepting our invitation for this lecture today. It is a very important lecture actually on CRPS. Most of the people, they don't consider it important in the sense that they consider it that it is associated only with the chronic pain physicians or those who are rotating in the chronic pain. But in the end, it is also a very important topic for those who are taking the exams or for those who are appearing in part 2 FCPS or any other relevant examination. So it is one of the most important topic. And Dr. Sidra, you have elaborately spoken on the latest updates as well as the latest classification, which is of 2023. So thank you so very much. I think, and I'm sure that most of the questions have been answered by now. And for those who have attended the lecture, we would request to kindly fill in the feedback form so that you can get the e-certificate.
Thank you, Dr. Asma. So, any other question, or we should end the session?
Dr. Aksa, do we have any other questions in the chat box?
I think
No.
intraclavicular block has some efficacy in your experience.
No, I have never done infraclavicular for a CRPS syndrome. We have done the stellate ganglion block either by CM or by ultrasound. But in my experience, I haven't seen a patient who needed infraclavicular, because infraclavicular might also be significant in those patients who have distal neuropathy. But Otherwise, because the ganglion is involved, so that's why sympathetic neurolysis is important rather than an individual peripheral nerve block, to my understanding and according to the literature as well. Because we need to understand what exactly is the pathology. The pathology usually lies in the sympathetic ganglion, at the sympathetic ganglion level, whether it's distal limb or it's in the mid part. But the main pain which is coming from it involves the sympathetic ganglion, and that's why we do sympathetic neurolysis in such kind of patients, which is stellate ganglion block for the upper limbs. And for lower limb, there are other sympatholytic injections which are effective in such kind of patients.
I think all the questions have been answered by now, and I would only like to add one remarks that all the people who are our anesthesiologists who are dealing with the anesthesia only and not the chronic pain services, it is very important for them as well to recognize the role of treatment during and post surgery for the pain, especially if the patient is left in pain after surgery and the patient who is already coming with the psychological stress and some kind of genetic issues and autonomic disease, because today we know that these are the precipitating factors for development of CRPS. So we can play our role perioperatively to reduce their symptoms, and we can prevent in such way that the CRPS is not developed after such kind of interventions as well. So this is the only comment I can give, and I don't think we have any question left. There is a question about
baclofen. We can use baclofen intrathecally in CRPS, but it's not normally used, and it's a very low level of evidence for baclofen.
Yes, it's a very low level of evidence.
Basically, I think it improves the dystonia or any spasticity, these type of symptoms in CRPS only.
Only in stage 3, I think, and very rarely used. Yes.
Yes. Side effects are more, so and good effects are less. So it's not used normally.
So thank you, Dr. Sidra Javed, for such good and simplified talk. I think we can end our session. Please fill in the online feedback forms for the e-certificate, everyone. Thank you so much once again, Dr. Sidra and Dr. Asma. And
thank you, Dr. Aksa, Dr. Asma, and all the colleagues for listening.
Okay, thank you, and Allah Hafiz, everyone. We are ending.